Now, you're going to hear from several other people who are far more expert about clinical integration than myself. And the first is I'd like to introduce Dr. Stephen Kohtz, who is the chairman of the Select Medical Network Clinical Integration Committee, to tell you more about how we're positioning to manage the health of populations in this seamless fashion. Steve?
Thanks, David. Appreciate it. It's just a quick introduction. My name is Stephen Kohtz. I'm a family medicine physician out in Twin Falls, Idaho, and it's just a real honor to be able to stand in front of you today and talk. I'll try and make it brief so that we have plenty of time. I think the question and answers are by far the most important. It's hard to follow the leaders of the health system, the network, and one of our physician leaders, especially as dynamic as you are. I like to think of the three people you just heard from as being the face of healthcare, and if we're lucky, maybe I get to be the chief of staff. And this is the clinical integration committee. In my opinion, is really that group who gets down to the nuts and bolts of how are we going to make all these high-level decisions work. Now, I just want to say something that I've held on to for a number of years, and I heard this from Jeff, so I'm going to throw Jeff under the bus on this one. But the clinical integration program is developing and differentiating product that will be recognized by insurers, employers, and patients, who will be the ones who drive demand for our product and our service. If you look at, if we look back to the why notes, I really think that was powerful, Jeff, talking about that Intermountain Healthcare really has a AA+ rating, and it does. You mentioned it. It says in their AA+ rating packet that they can influence the behavior of patients and providers. And people who have gone down to ATP at Salt Lake City, they'll say the reason they've done it is because it's the right thing to do. They standardize the way care is given wherever they can, and as a byproduct, both that standardization leads to an improvement in quality and a decrease in cost. And I don't think that's intuitive for a lot of people. Why would that do that? But if you're a provider, I think it's very intuitive. If you standardize the way knees are replaced or hips are replaced, and that leads to a significant decrease in the really, really high cost care, which is infection rate, then suddenly you've got everybody on the same axle. It's decreasing costs, it's improving quality, and physicians can be proud to be a part of that. So I'd like to go to the next slide here. What do we mean by clinical integration? I've heard Jim Souza a couple times, and I really like this. I've stolen it from you. Is that if it's too long to remember, then it's probably too long to be able to advocate. So when I think of clinical integration, I really think of it as making the right thing to do also the easy thing to do. Setting it up so that the system supports you to do the right thing when you need to do it. And if you boil this down, I believe that's what this is saying, is setting up any provider in the network to do the right thing when they need it. Some examples of clinical integration you've heard through this conference. So how powerful was it that the patient could tell that our patient yesterday could tell that his physicians were talking to each other, that the physician was not asking the patient, how long were you in the hospital? What were your diagnoses? By the way, what did they discharge you on? What medicines? Could you tell me? I'll put that in your chart. The physicians knew, and the patient could tell the difference. Other examples of clinical integration, you just saw White Cloud. How powerful is White Cloud? Thank you. In terms of being able to get physicians wrapped around a common axle, being able to say, this is our population that we're responsible for, and by the way, this is how you're doing. A little bit of just a little side note, the clinical integration has got to be a network focus. And David, I think that was a powerful slide earlier where we need to make sure that the right thing to do is the easy thing to do for any provider, whether they're a St. Luke's Health Clinic provider or a non-affiliated, quote unquote, provider. How do we become clinically integrated? There's a lot of confusion between performance improvement and clinical integration. They rely on each other, but clinical integration is really setting a support system around a provider so that once again it improves and makes easy to do the right thing for the patient in front of you, and that necessitates working among providers. So I don't think anybody here would disagree with me if I said that no matter how good of a family medicine physician I am, I'm not going to take as good of care of a patient as if I am taking care of a patient along with all of my specialty colleagues, my ER docs, the cardiologists, the surgeons. The clinical integrations initiatives are really being stood up in a way to support all the physicians in working together to surround the patient in their care. Once again, a great example, we just heard from Brian Fortune and White Cloud that transparency and accountability is how we will be successful in our White Cloud product, which absolutely is a clinical integration initiative. The point was right on. A lot of my specialty colleagues today look at White Cloud and they're not quite sure what it means to them. And we'll talk about this in a little bit, but through our measures subcommittee, we want our specialist colleagues to tell us what's meaningful to them. What really does drive high quality care for you as a general surgeon or a cardiologist. And that's actually what we want on White Cloud. Where do new CIIs come from? Well, they kind of bubble up, frankly. There are these requests for initial charter process. They, as an initial proof of concept, they come in front of this CIC group who is mostly composed of physicians. And those physicians will say, well, does this really pass snuff? Is there medical evidence to support what you're doing? And if so, go ahead and move out, fill out all the data that it's going to take to, get us an idea of what are the resource costs, what's success look like, and then come back to us with a charter. And that charter we're going to look through, and we're going to either approve or disapprove, and we're going to prioritize it. Because in my opinion, it's clear that we're going to have a lot more requests for resources than we actually have resources. We are going to have to be very careful on what we spend our money on, so that we know that it's the most important things that can move the bar the quickest. You'll notice there on the bottom the annual process now collecting for 2005. So this is a great example, once again, of what we've been talking about at this summit. So I'm looking forward to seeing the charter for an obesity work group inside Select Health or St. Luke's Health System. There are more than 20 different programs who are working on obesity. And do those 20 programs sit down together and talk about what they're doing? Do they have the same success metrics? Can we show that to an employer today and say, look, we bent the curve and we saved you $10 million on your cost because of this program? The answer is no, obviously. But is that where we want to go? Absolutely. And that's what we're talking about for high-impact clinical integration initiatives. As a note, now collecting for 2005, so if you have your great idea, please come talk to me. So current clinical integration initiatives, I'm just going to talk about a few of these. I'm not going to talk through all of them. Like I said, I think the Q&A session towards the end of this is going to be much more powerful. Care management. So we already understand why we need to have care management, and that was because of our population health tool on White Cloud. For the first time, we can now actually work with our insurance partners to identify who those patients are who really need help, who maybe can't afford their medicines or don't have a car to get to the doctor's office, things that we can't control, but we now know who they are so that we can get them the resources they need to control that outcome. The care management particularly, it's interesting. I have to say this specific patient, not that I'm going to talk about PHI. I can remember one patient in particular who had cost $400,000 in terms of medical care costs, and their diagnosis on their White Cloud was abnormal sugar, not diabetes, just abnormal sugar. And if you put a score to that patient, if one is a normal patient's health, their score was 0.7. So this person who cost $400,000 was healthier than the average person? Does that make sense? And this care management, in my opinion, is the low-hanging fruit. Getting at what Jeff was saying earlier, this race, we are in a race across the entire country to eliminate that 30% of waste. That's one of the big ways we get at decreasing and eliminating waste. And by the way, if we can actually identify that patient, which now we can, and get them the help they need, maybe not only do we cost less, but now we're maybe a little bit more appropriately coding so that the insurance company and even St. Luke's or Select Medical gets paid appropriately for that expensive care. And more on that later. Shared analytics, my goodness, was that powerful or what? You know, for those who haven't seen White Cloud demonstrated, that is a fantastic tool, and it's continuing to evolve. Once again, that measures subcommittee who's really owning the data on that White Cloud, they are doing fantastic work, and I look forward to moving forward on that. Pharmacy optimization, just to repeat, we now have a single inpatient formulary with some rare exception across all of our St. Luke's Health System entities. That was not the case until February of this year. That is a Herculean effort, and it's going to be an even larger effort to move to the outpatient. But from a provider standpoint, we as providers constantly are wondering what's on the formulary for that patient's insurance. You know, I need to prescribe a torvastatin or a statin. I wonder what it's going to have to cost that patient out of pocket, and I'm trying to look that up and help them. How wonderful would it be that if I'm a physician, that there's one formulary, that I have a patient and the formulary we offer is part of our service so that our physicians know what's our formulary. And not only that, that formulary is one that we're in control of so we can maximize the benefit, you know, give us the most bang for our buck in terms of utilizing the medicines that are most useful. And then going on to the next one, the 2014 Clinical Integration Initiatives. I'm going to spend a little bit of time talking about this accurate coding and documentation. Once again, this is, in my opinion, matching, you know, the win-win-win. So if you look to get a little technical here, if you look at our populations, Medicare will take John Doe, and when John Doe goes to see his physician and his physician codes diabetes and high blood pressure, we submit that to Medicare, and Medicare says, okay, you're this age, you're this sick, and it's gonna cost you this much to take care of the patient, here's your check. That'll go to the insurance company, and the insurance company currently is in charge of making sure that the output is less than the input, as it were, from Dr. Nash yesterday. Now, based upon that population health tool, and without pulling it up and going through it, we've identified there is a lot of opportunity for us to be more appropriately caring for our patients. For instance, that patient who costs $400,000 and is healthier than the rest of us, that's a clear example of someone who may not be getting the care that they need from their primary care physician, who would probably be coding those things as they saw them if they were able to see them. The win-win-win here is that for the first time, we can now identify patients who aren't getting in to see their primary care physician or their specialty physician, depending on their conditions, and help them get in. And when they get in and they're cared for these conditions, those conditions are coded, they're billed for, and not only does the health system survive, because currently we're in mostly a fee-for-service world, but also the insurance company actually survives because they're getting appropriate reimbursement from Medicare for their services. This is going to be a huge project, but a very worthy one, in my opinion, in the near future.